Thank you for coming to the library tonight for our program. I just wanted to let you know that there's a bathroom over there if anybody needs to use it during the program, and that this program is being recorded by Orca. So they're back in the corner right over there. And then I'm going to introduce Emily, who's going to introduce our speaker.
Hi everyone. If you can't hear me or Kelly when she starts presenting, just raise your hand. My name is Emily McKenna. I oversee marketing and development at CVHHH. I want to tell you a little bit about the agency before we get started. We are a nonprofit visiting nurse association. We're one of 8 in Vermont. We were founded in Montpelier in 1911. We've been here for over 110 years, and we provide home health care, hospice care, which is end-of-life care. With Kelly on board for the past 2.5 years, we have an outpatient palliative care program, which we'll talk about in the presentation. We have a maternal and family child health program and long-term care. So we really take care of Central Vermonters of all ages and at all stages of life. Being a nonprofit, we're driven by a mission, which means that we care for anyone regardless of their insurance status or their ability to pay. And I think it's really important to everyone that works at the agency, the connection to the community. Everyone at the agency has some roots here, be it through themselves. They were born and raised here, they live here now. Many of the people who work at the agency have family members who were cared for by someone at some point. So we really do pride ourselves on how connected and embedded we are in the community. Kelly Elwell is our doctor of nursing practice, and she oversees the outpatient palliative care program. It's a consultative program. It was founded in 2023, and with the program we really wanted to reach a new population of people in the community who aren't quite at the end of life, but who want to be engaged with advanced care planning, may have a new diagnosis, and they have a lot of questions, and they want to understand how to prepare for what's coming. Kelly is amazing. She's grown the program and built it over the past 2.5 years. And tonight we will talk about advanced care planning, our palliative care program, and hospice care. And I would say feel free to raise your hand, and we'll make it as interactive as possible. So, Kelly?
Thank you all for coming tonight. So again, my name is Kelly Elwell. I am a nurse practitioner. I am board certified in family medicine. I was a hospitalist at Porter Medical Center prior to this role, and I have a background in oncology and dementia care as well. So as Emily alluded, a lot of us that work at the agency have deep roots. I am a 6th generation Vermonter. I actually started my healthcare career at Central Vermont Home Health and Hospice when I was 17. I became a personal care attendant, and then I went off to school and did all the things. And now I'm a doctor of nursing practice, and I'm back working for the agency. And we developed the palliative care program to help folks with pain and symptom management, but also advanced care planning, which is really, it's something that doesn't get a lot of attention because doctor's visits are really short typically, and it's hard to have these hard conversations in a short amount of time. So we'll get started. So we'll talk a little bit about life-limiting illnesses and what that means, steps for advanced care planning, how to choose your healthcare agent or your durable power of attorney, exploring preferences and understanding what CPR is. It's not like what you see in the movies or on TV, so we'll talk about that a little bit. I want you to engage with your providers, your current care team, and talk to them about your healthcare wishes and your current health status. We'll talk about documentation, what palliative and hospice care is, and then again we'll take questions that'll be interactive. If there's a question that's very specific to you personally and you don't think that applies to other folks, we can take those at the very end. If there's questions that you think will apply to the group, then we can take those during the talk, okay? So advanced care planning is the process of exploring wishes and sharing your preferences with family and your designated healthcare agent in order to prepare for the end of life. And I recommend that you do this for anyone that's over the age of 18. So life-limiting illnesses include neurocognitive, which is dementia, Alzheimer's, Lewy body, Parkinson's, a traumatic brain injury or a TBI, or a stroke. Any cardiac illnesses, including CHF, which is congestive heart failure, valvular disease, or heart attack. Pulmonary, which is lungs. We think of COPD, emphysema, interstitial lung disease, and COVID at one time or another was a severe illness. In some folks it still is. It's not as severe as it once was. And renal, which is kidney, chronic kidney disease, folks that have acute kidney injury related to a hospitalization or medication, sepsis. And then folks that are on dialysis or that potentially could need dialysis. They have a life-limiting illness that would qualify them for palliative care. Any cancer diagnosis, so breast, lung, colorectal, prostate, endometrial, pancreatic, kidney, melanoma, basically any cancer that can't just be simply removed in the office it could be considered a life-limiting illness. So I always say that we're always hoping for the best, but we plan for the worst. So palliative care is an extra layer of support that helps you to plan for the future, but also it's a safety net of if something doesn't go the way we're hoping, that you have a backup plan. So the step one for advanced care planning is to choose a healthcare agent. And that is someone that you trust, that is over the age of 18, that can make good decisions on your behalf. Step two is to explore the personal preferences and wishes, and then talk to your medical provider. Step four is document and share, and we'll talk about what that means. And then I recommend revisiting this once a year. If something changes with your health status or your wishes, then you could do that more frequently, but typically every year is a good plan. So you want to choose someone that can be your voice when you can no longer speak for yourself. So you want to choose an agent that is willing and able to carry out your wishes, even if they differ from your own. It needs to be someone that you trust, and the agent's job is to follow your documented wishes. It doesn't mean that your agent is going to come up with their own plan for you. It means that you are going to have your wishes spelled out, and they're there to follow them, okay? Doesn't mean that your spouse or that your eldest son is the right person for the job. Sometimes it's a person that's kind of more neutral, that knows you well, is a better person. So it's all up to you. It's a preference. There's no right or wrong on who's your healthcare agent. In your packet, you're going to see an advanced directive, and we put the short form in there. There is a long form, and that is something that you can find online. I prefer the short form for these types of activities because the long form goes into way greater detail than we need to here. But we will go through each section, so feel free to fill that out as we go if you are so inclined. Today we can actually witness these, and you can leave with a completed document if you choose to. Otherwise it'll be there for you when you're ready to complete it. So section 1 of this form, the person that is your healthcare agent it could be a relative, but it needs to be someone that you trust and understands and agrees to act as your agent. This person cannot be your healthcare provider unless they are a relative, an owner, operator, employee, or contractor of residential care facility or healthcare facility where you reside at the time of your advance directive is completed. You're also going to mark when this directive takes place. So there's a section on the form that says, I want this to take place when this happens, or I want this to take place when I lose capacity to make my own medical decisions, or I want that to start now. So you have that choice. If you decide to only choose a healthcare agent and do nothing else on the form, filling that one section out and signing it on the back is a legal document. That'll at least appoint someone as your go-to, okay? I prefer that you fill out the entire form, but you don't have to. So the next steps, we explore things that are personal preferences. So what means the most to you? Who would you trust to follow your wishes? Where do you prefer to die if you had a choice? How do you prefer your death to go? Some folks really want in a facility medicalized with all the technology to keep them comfortable. Other folks want a more natural approach and they just want what's necessary to be comfortable. And what do you value most? Do you want quantity of life or quality of life? And again, those are all personal preferences. There's no right or wrong to that. But understanding what you value is really important to help you answer the next set of questions. There's things that I call hard no's. This means that interventions that would be unacceptable to you, situations that would be worse than death. And this is also individualized. For some folks, they would never want to be on a breathing machine. That's like the cutoff. I don't want to live on a machine. Other folks say, I don't want an NG tube, which is a tube that goes into your nose, down into your belly. It could be something that's very invasive, or it could be something that's not so invasive. But this is something that you need to decide for yourself. Of course, we can't plan for all situations, but by filling this out and answering the few questions that are on there, it's going to help your healthcare agent and your medical team decide if something comes up that's not on that form, what your baseline goals were and what you were willing to go through to sustain life. You can also add people that you don't want involved in your care. In the state of Vermont, if you do not have a healthcare agent form filled out, it doesn't automatically go to someone like your spouse or your eldest child, for example. There's no algorithm for that. It's really who shows up to the hospital, who knows you best, and who they can communicate with to say, are you the right person to make decisions? And again, this is only if you don't have a document filled out that spells out who you want to make decisions for you. And then understanding what code status means. So some people, we call it DNR forms, we call it do not resuscitate, but code status refers to whether you want to have resuscitation for life-sustaining measures. Okay? So having a good understanding of what those interventions entail, looking at the bigger picture of overall health when deciding what you feel you would want in your 20s when you're healthy and have no medical problems is probably very different than what you feel at 65 when you have kidney disease and cancer and heart disease. So these things will change over time as well. And realizing that life-limiting illnesses such as heart disease, cancer, high blood pressure, kidney disease, how that affects resuscitation. And we'll talk a little bit about that. And again, it's not what you see in the movies. It's good entertainment, but it's certainly not how things go when something happens. So on section 2, your healthcare goals and spiritual wishes, this is basically saying how much treatment and intervention do you want to sustain your life? So your overall health goals includes, the first option is I want everything. I want everything medically possible to keep me alive for as long as possible. The next section is I want treatment to sustain my life, but I only want to be here and be treated and sustain my life if I can interact with my family and be comfortable and have some quality of life and take care of myself. So you can kind of choose things that are important to you and write those in there. Or I only want treatment directed towards my comfort, meaning I don't want to go back to the hospital, I don't want to have CPR, I don't want to have anything invasive that would be burdensome to me. I just want to be comfortable and let nature take its course. So as with anything, there's no guarantees in life or in medicine. Lots of times when I'm filling out these forms with patients, they say, well, I only want resuscitation if. And it's really hard. We can't make any guarantees. We can't promise that you'll survive. We can't promise that the extent of your recovery and what that'll look like. You can't just have a little bit of CPR, right? Sometimes people are like, oh, just do it once. Well, that's not really how it works. Or I only want chest compressions, but I don't want a breathing tube. Well, it's a package deal. So CPR is cardiopulmonary resuscitation, and it includes chest compressions, intubation, mechanical ventilation, defibrillation, and transfer to the hospital in the ICU. So chest compressions is pushing forcefully on the chest to circulate blood to the organs. So basically the heart is a muscle and there's valves and blood, and that's the plumbing section of the heart, right? And then there's an electrical component, and the electrical impulse makes the heart do the activity that it needs to do to circulate the blood. So we can only shock 2 to 3 rhythms, and we can't shock a dead heart. Right? So defibrillation is shocking. So in addition to the chest compressions, we will scan your heart with, you see those sticky pads that you see in the movies? That's scanning to see if you have any electrical activity. And if you have one of the shockable rhythms, we can shock you to see if we can get you back in a normal rhythm. Unfortunately, it doesn't fix things. It doesn't give you electricity to restart it, right? It's more of just trying to take what electrical activity is in there and making it a more normal rhythm. We will also intubate you, which is an artificial airway. It's a breathing tube that goes into the mouth, down into the lungs, and if anyone's heard of being on a breathing machine or a ventilator, that ventilator is doing the work of breathing for you. Unfortunately, we have to sedate you to the point where you don't breathe on your own, because we have to allow the machine to do the work for you. Otherwise, your body will reject the machine. So you're also pretty sedated, if not unconscious. And then we give you IV medications as well. So this is just CPR, okay?
What's it called, excuse me, when you can't breathe through your mouth and you have to actually...
Yeah, tracheostomy. Yeah.
Tracheotomy.
Yep. So the risks versus benefits of CPR. So in this picture, you can see that this is a side view of the chest wall, okay? And it's a little hard to see, but you can see that there's a lot of rib fractures here. The sternum is probably also broken. These are fractured ribs. And sometimes what happens is that because we have to push so forcefully, about 1/3 of the depth of the chest, so that's going to be different for everyone, but 1/3 of the depth of the chest, about 100 times a minute, to circulate the blood. So what can happen is those ribs can break, they can puncture a lung, and then you can have a pneumothorax, which is, this is the normal lung, takes up the entire space. A collapsed lung, when the pressure is not equalized and there's a pinhole or a fractured rib that pokes a hole, it can cause deflation of that lung. And so that also causes issues with coming off a ventilator, because now you have damage to those lungs. CPR is not as effective as people think. It's not like you see in the movies where they do CPR and then the person walks out of the hospital that day and everything's fine. Typically, if you have a medical event inside of a hospital, you are, that's non-traumatic, and we'll talk about what that means, your survival rate is about 9.1%. If you're outside of a hospital facility and you don't have all the modern medicine technology, it drops significantly. Yes, you had a question.
I think you just did it, but explain more about that bottom paragraph.
Yeah. Yes. So if you are in the hospital and you have a team of folks that are there, and you have all the medicine and all the things you need and ventilator and all the things, you have a little bit over a 9% chance of survival and coming back to the person you are today. If you are outside of the hospital, that number continues to drop. And then when you have medical comorbidities or life-limiting illnesses, that also weighs in on that number. Does that make sense?
Wow.
Is that correct?
Yes. So if it's completed outside the hospital, survival rate is 9, right, for non-traumatic events. So this does not take in consideration for, does anybody watch football? The gentleman that got hit in the chest, that was a traumatic event, right? So this only takes in consideration for folks that have a medical problem that caused the issue. It doesn't take in consideration for the folks that have a car accident, or they get hit in the chest, things like that. Yeah. Okay.
What would a choking incident be? Would that be non-traumatic?
That would be a little bit different because a choking incident, you're gonna lose your airway, and because you've lost your airway potentially, then it would affect your heart. So it's not a heart problem, it's that you're not getting enough oxygen, which in turn affects the heart. Does that make sense?
No.
So so you have to have oxygenated blood for any organs to function, right? So if you choke and you cut off the air supply, then you are going to have tissue death, basically. The heart isn't able to function the way it should, and the tissue starts to die. So that would be different than a medical problem causing like a heart attack.
How would that fit in the bottom paragraph of the previous screen?
It depends. I don't have any statistics off the top of my head.
That bottom paragraph is very confusing.
And I'm sorry. Basically, you have a slim chance of coming back to the person you are today if you were to have a medical event that causes your heart to stop where you need CPR and intubation. Okay?
That's clearer.
Good. Okay, so limitations of treatment. So on this section, section 3, what do I do if my heart stops? Would I want to have resuscitation? If I'm unable to breathe on my own? If I'm unable to eat or drink on my own? Or if I'm terminally ill? These questions are important. They can be answered individually. For example, if you choose to have CPR, which is cardiopulmonary resuscitation, you have to choose that you want chest compressions and intubation, right? That's a package deal. But let's say that you have COVID and your heart's working just fine, but your breathing isn't. We can intubate you to protect your airway and breathe for you while you recover from that. But that doesn't mean you need CPR. We're intubating you to protect your airway so that your lungs can recover and hopefully you can come off that machine. So that's a different reason to intubate. The other reason we intubate folks is for planned surgery. So you go for a hip replacement and you have to have a pre-op to make sure that you're stable enough for that. That is a different type of intubation, right? So in these questions, it's asking you, if you want CPR, then you get intubation automatically, if you were to need it. If you were to only need intubation because your lungs aren't working right, would you want that, right? And that's a separate question. If there's limitations that you pick on the advanced care planning form, then you also need a COLST form, and we'll talk a little bit about that. So the advanced care planning form is really to delegate your healthcare agent and also explore your wishes and document your wishes. But I like to consider the COLST form, or the clinician order for life-sustaining treatment, as the prescription that tells EMS and outside facilities other than the hospital what you want your healthcare to look like. So if there's limitations of things you do not want, then we would complete a form that's considered, yep, and it's that one right there, the COLST form, okay? If you're a full code and you want everything done, you do not need to complete that. The next section, section 4, talks about organ and tissue donation and burial. And that's pretty self-explanatory, whether you want a cremation, burial, a funeral service, where you want to be buried. Do you have pre-made funeral plans? You can write that in as well. Who do you authorize to create your funeral plans if you do not have them already? Yeah, you have a question? And then on the bottom of that form, it goes into, can I borrow that for just a second? Antibiotics. So antibiotics at the end of life can be for comfort, or it can be to help cure infection. So sometimes infections are really painful and we choose to give antibiotics to alleviate pain and promote comfort, and other times folks will decide, I don't want to have antibiotics because I would rather die a natural death We see that a lot in folks that have dementia or neurocognitive disorders. Sometimes they choose not to treat because that's a very humane way to end their life naturally. So that's another personal preference, that you can choose to either have antibiotics or not, depending on your personal wishes. So I encourage you to talk about your unique situation with your primary care provider or a palliative care provider. If you have home health, you can talk about them with your nursing staff at the hospital, and you want to understand your diagnoses that are pertinent to you, the prognosis, the treatment options, the risks versus benefits of treatment, and what it would look like if you didn't get treatment. And then you want to document your goals of care and make sure that your folks that are in charge of your wishes understand and know them well, so that if they get a call, they understand what your goals are. So in the last section of the short form, you need to have 2 witnesses. So you would sign at the top line, and then 2 witnesses. They can be anyone, just not someone that's named on the form, and no immediate family or family that can witness. Anyone that's in this room, you don't have to know each other, you could witness each other's. It doesn't have to be a notary, and it doesn't have to be a healthcare provider. For the COLST form, that does need to be a nurse practitioner, a PA, or a medical doctor that completes that form with you. And who should get copies of your advance directive? I recommend that you send a copy to your healthcare agent. Keep a copy on your fridge. Make sure that your doctor's office and the local hospital that you use most often has that on file for you. And every time that you make updates, you have to update all of those places.
Isn't there an online directory?
What's that?
Isn't there an online directory?
There is an online directory, and there's actually a form that's attached to that. You can absolutely send it to the directory. You just have to sign that you agree to that. You cannot rely on the directory to be there, only because it's not something that people will, if something happens and you're out in public, and they're not going to look at the directory. So having the document readily available, especially at home, is helpful.
Can I ask a quick question about?
Of course.
In Vermont, we have the UVM Health Network. If you live in Montpelier, CDMC is your local hospital.
Mhm.
If they have it, it will be accessible to every hospital in the network, correct?
It should be. We can't, so for example, if you have a Gifford provider, but you sometimes use the hospital here or vice versa, you would want to make sure that both facilities have
Okay.
the advance directive and the COLST form. We have access at our agency to Central Vermont Medical Center's records, but we also scan it into our chart to make sure that we have it. So it's just best practice is to make sure that every place that you seek care has it. So a lot of questions that I get about living will versus advance directive. Basically, a living will is an older document. Some people still have those because they created them many years ago, but now they are, the new forms are the advance directive forms. If you have a living will, that's still valid. So you don't have to necessarily redo it unless there's any updates to it. So the COLST form is a medical order that must be signed by a provider that indicates your wishes. And this is, again, this is only done if you have limitations that you want on your care. If you want everything done to revive you and sustain your life medically, then you do not fill one of these forms out. And the form looks like this. So the top section is CPR versus no CPR. The only time I've ever filled out a yes to CPR is if someone's going from a no resuscitation back to resuscitation, just to make that very clear.
Provided it's the default.
The default is to do everything, absolutely, yep. And then that second section is, would you want intubation? Now, obviously, if you want CPR, you automatically get intubation. This question is geared towards if you had COVID, or you had lung cancer, or you had a collapsed lung, would you want us to intubate you to protect your airway, as opposed to, and your heart's still beating, as opposed to you've passed away and we're trying to resuscitate you. Section C talks about how much care you want. Do you want everything done? Do you want only comfort care, meaning you don't want to return to the hospital, you don't want to have anything invasive done, you just want to be comfortable? Or do you want something in the middle, which would be the middle section there, that you want available treatment, but you'd like to stay out of the ICU, and you really don't want invasive measures? The back of that form talks about artificial nutrition and hydration, as well as antibiotics. And it does give you some leeway there. It says, of course I want those things. If I couldn't eat or drink to sustain life, of course I want a feeding tube. Or maybe if I'm gonna get better, I'll try it for a little while. Or absolutely not, I don't want that ever. So it kind of gives you a little bit of leeway in your decision making, because we can't plan for everything, right? We just don't know. And same with the antibiotics. Of course I want antibiotics, or we'll try it and see what happens, but I would rather be just used for comfort, or absolutely not, I don't want antibiotics. So as we talked a little bit earlier about palliative care, so it's specialty medical care for anyone living with life-limiting illness, and earlier interventions are best. We offer the consultative program for individuals facing serious illness. And I work with primary care providers and specialists. So I see folks, you don't need a referral. You can just call and ask for a palliative consult. I come out, I meet with you and your family, or whoever you choose to be at the appointment, and we talk about advanced care planning, pain and symptom management, possible prognosis and treatment options for whatever's happening. And then we talk about end-of-life planning. It's a service that I offer recommendations for, so I will give those recommendations back to the primary care or your medical home, and they will choose to carry those out as far as prescription writing or things like that. So on palliative care, I do not write prescriptions because I don't want to interfere with your relationship with your current care team, okay? Hospice care is specialized care that's multidisciplinary approach. So you have nursing, you have chaplain, you have social work, and it's basically to care for you at the end of life and keep you home or in a facility, wherever it is that you're located, when you have a terminal illness or a terminal diagnosis that you wish to not seek treatment for. So this is the 3 requirements for hospice is you have to have a terminal illness that says if you do not treat, your likely survival time is less than 6 months. Doesn't mean that that's what's going to happen, right? We have patients on hospice for years sometimes, or sometimes patients come onto hospice and they stabilize and they don't qualify for hospice anymore because they're not continuing to decline from their illness. The other requirement is that you have to choose the service. We can't sign you up for hospice. It's voluntary. And the third is that it is a Medicare, Medicaid, and private insurance benefit, so it's no cost to you. You don't have to pay out of pocket for the actual care that you get from hospice. They do not pay room and board at a facility, however. So you still have to have a care team that's caring for you. This is an extra layer of support.
So it says here, no palliative treatments.
Mm-hmm.
Must be willing to forego
Curative treatments, yep.
curative or palliative treatments. Isn't hospice care palliative?
No, yes and no. So sometimes we do palliative radiation, for example. So palliative treatment isn't going to fix the problem. It's for pain and symptom management. So in that case, we don't typically do radiation on hospice. Doesn't mean that it can't happen, but typically it doesn't. So that's what that means. But yes, you're right. You forego getting further chemotherapy or further surgeries. And everything that's on hospice, it is palliative, right? We're trying to palliate. To palliate is to make comfortable. But it's not, we won't, the hospice benefit won't pay for palliative treatments in effort to slow progression.
So sort of a difference between palliative care and palliative treatments, is that what you mean?
Yep, so all hospice care is palliative,
That's
right?
okay.
But palliative treatment, again, is more related to the interventions that are done to slow the progression or to, like I said, radiation's the best example. Yeah.
Yeah, what about other medications that you're taking?
Yeah,
I've been unclear about that.
on hospice, you mean?
Yeah.
Yeah, so the hospice benefit encompasses the admitting diagnosis and anything that's related to the admitting diagnosis.
But not other things.
Other things. So the best example I can give you is, let's say you are on hospice for cancer, but you have cataracts and you would like to go have that taken care of, right? Your cataracts have nothing to do with your cancer diagnosis. You can go and do that. You can take the medications for that, but anything related to the cancer, whether that's pain or symptoms or things that develop because of the cancer, we cover and take care of, and we wouldn't try to cure those things. But you can absolutely, for quality of life, you could go have cataract surgery while you're on hospice, depending, and you'd have to talk to your hospice provider, right? But that happens. Yeah. So we don't take all of your medications away, for sure, right? We take the things, we stop the things that aren't going to help you be comfortable, because the goal is comfort. So again, advanced care planning is just the process. It's not a one and done. It's done over time. It changes over time as your health changes or as you age. And this is just a process where we prepare documents to make sure that everyone knows who's on your care team knows what you would want and what you would speak for yourself if you could speak for yourself at the time of something happening. And life-limiting illness takes so much from patients, and advanced care planning gives some of that power back and some of that autonomy back. So if you're able to speak for yourself now and get that written down, then we can follow those orders when you get to a point where you can't speak for yourself. Gives you a little control back. Does anybody have any questions? Yeah.
When you choose someone to be
Your healthcare agent,
healthcare
yeah.
agent, have you found it's important that they be able to get there fast? Like I have someone named who's in New Jersey.
No, not at all. Not at all. Because we can call folks, we don't need to have them right there. You can choose anyone. I mean, I will tell you it's a lot easier if they're in the United States and that they have us, you know, we've had some people say, oh, I only have an email for my healthcare agent. That's really tricky, right? So if they have a good working phone number and they're, you know, able to get a hold of them, that's all we need.
I don't feel it's important to be in the room and look at you.
No. I mean, they're gonna give, the medical professionals are gonna give kind of an update of what's happening and where you're at. So, and these really, a lot of these documents, especially the Coles form, is really meant for out-of-hospital orders. So it's for ambulance, it's for home health, it's for folks that are going into the patient's home or seeing people out and about. It's not meant for the hospital. The hospital will ask you every single time you're admitted, are you a full code or are you not a full code? Are there limitations? So they will update that chart accordingly every time you're admitted. Yeah, so it does not have to be someone that's local. A lot of people don't have somebody that's local. Yeah, that's a good question. Any other questions?
Yeah. Expanding on that one
Yeah.
question, because I did the advanced care directive when I lived in Germany.
Oh, wow.
And I have everything in Germany. That probably does not apply over here, right?
So, yes and no. I would say wherever you're a permanent resident is where you should have it done. So if you live here now and you plan on staying here now, you should get it done on a Vermont form. If you, say, came from Connecticut and you moved up here and you had a do not resuscitate from there and you had an advanced directive, we're going to follow that, right? It's legal. But my kind of rule of thumb is if you're going to live here and you stay here, it should be from here. We have snowbirds, right, that go back and forth to different states, and I can't speak for every state and I can't speak for every hospital and every provider, but generally those should be validated, that they're valid. Okay. Germany, I've never had one from Germany, so I would love to see what that looks like.
Well, I mean, you have the language then, the document I signed was in German.
Oh,
So the
that's a
thing
whole
is,
thing.
Would that have to be translated into English? probably.
Yeah, we should just do a new one.
Yeah.
Any other questions? Yeah.
In the past, I've been aware of two instances where somebody I know had an accident away from home.
Yep.
And on their fridge at home was a document,
Mm-hmm.
and they had one on file with the registry.
Yep.
They were immediately picked up by the EMS and taken to the hospital, which was the last thing they wanted.
Yep.
How do you deal with the EMS?
Yeah, so in the state of Vermont, I can't speak for outside of the state,
Okay.
but they do recognize DNR bracelets, so do not resuscitate bracelets. And you have to file your COLST form with this company and purchase it from, and I can get you those names. And it's a bracelet that you wear and it says do not resuscitate and maybe your name. And they will, EMS in the state of Vermont will recognize that. You're right in that if you have an accident, even in Vermont, and you're out and about and something happens and your COLST form is on your fridge, even if you have a bracelet but it's not well noted, could CPR get started? Absolutely. We can't promise that if you fill this form out that you're never going to have resuscitation. And that goes for surgery too. If you have surgery, typically, and I can't speak for every surgeon everywhere, but typically you are a full code while you have surgery. It's null and void during the surgery and so many hours after, and then it reactivates.
And this may be something different than that, but doesn't the directive give you, the registry,
Mm-hmm.
give you a card that you can keep in your car? Is that different than?
Yes, it is different. Yep. So the register, you're right. They give you a little card to keep in your wallet or in your car. But that just tells us that you have one. It doesn't tell us necessarily what's in it. And even if you have an advanced directive, and it says do not resuscitate, you really need that medical order, which is the COLST form.
Okay.
Yeah.
I have also another question
Yeah.
about, I'm seriously considering the green burial.
Yeah.
And my understanding is that you cannot choose an area or a plot, whatever you want to call it, before you're just ready to die, like maybe a month or 2 months. I'm not remembering what it is. And the reason for that is that if I were to buy something today, which you have to buy into it, number one.
Mm-hmm.
And so what you're getting is a deed for an area.
Okay.
But you can't select the area until you're about ready to die, because trees grow, all kinds of things happen. So you
Okay.
might want a spot right here
Yep.
where there's water, but then there may be trees or other things growing up there, and you
Yep.
can't be buried there. So this doesn't address that, but I'm assuming, I know when my mother was dying and I asked, well, do you have any idea how much longer? And the answer is always no.
Mm-hmm.
So how do you make those kinds of, how do you navigate through that?
Yep.
When you,
So I can only speak for what I've dealt with and what I know, right? There's probably a lot out there with green barrels that I'm not aware of. There is, I believe it's Green Mountain Cemetery, I'm just speaking.
Green Forest.
Yep, in Roxbury.
Roxbury.
Yep, so not that one. The one that I've dealt with recently with a patient was, I believe, Green Mountain Cemetery, and they do green barrels as well, and they paid for their plot, but that's something that's mowed and that's taken
Right.
care of, right? I can't speak for the other places. You can also do green barrel on your own property if your property meets the requirements. So that would be a question for them. I mean, when you're on hospice, then typically, right, you're 6 months or less, but we can't promise that.
Right.
We can't promise that. I think one of the things is if green barrel is really important to you, but it's also really important to you to know exactly where you're going to be, then maybe being in a traditional cemetery is best, or going with a cemetery that does green burial, but gives you a plot. Yeah, I can't really speak to that just because I don't know the ins and outs. I think they're doing a green burial presentation.
Had one at the senior center
Okay.
So I wonder who the contact was.
Yeah, we could
I can
probably
try to
find
find
out.
that and send it.
Yeah.
I can speak to the cemetery in Callis. You buy your deed and you get your plot.
You get your plot.
Yep.
Is that manicured and maintained? Yeah, that's not what I'm looking for.
Yeah,
I really
I
want
can
to be
understand.
on
I've
the
been to
horse.
Vermont Forest Cemetery, and they say you can specify what kind of location you
Hmm.
want, like by a stream or, under a tree. They're pretty flexible, so.
Where is this one?
That's the same one as yours.
In Roxbury.
Green Forest?
I think it's the same one.
It's like
Look at it.
Northfield,
It's called
Vermont
Yeah,
Forest
it's right out here,
Cemetery.
Vermont Forest
Mm.
Cemetery.
Yeah, in Roxbury.
Yeah.
Yes, oh, it's Vermont Forest.
I think that's what it's called.
Yeah,
something
so
like
I did it, yeah, so they say you can describe what kind of place you want, but they're also very flexible. I think you could say, save this place even if there's a pond there. You know?
They could throw you in the
Yeah,
pond.
so I don't know. Yeah, they could talk to them, but they're really.
Is the Coles form not valid until a clinician signs it?
Correct. Typically, the Coles forms are not something that you would fill out on your own. It has to be informed consent, so we would go over it with you.
Okay.
The only reason we provide it in this packet is for educational purposes.
Okay.
So I wouldn't recommend that you go fill it out on your own and then just have a provider sign it. I go through it line by line and make sure, just like if you get surgery and you have informed consent for surgical procedures, we have to explain and we have to make sure you have capacity to understand what that means.
Okay, and who, your clinician is typically your primary care?
It could be, yep, it could be palliative care, it could be, I can sign those today if you know what you want, I'm happy to work on that with you. But yes, your primary care can fill them out. If you went to the hospital and was interested, they could help you.
Okay, do people, who are just trying to do it early, like, do you just, if you go in for your like annual physical, just say, hey, I wanna tack on a
Yeah, you can
Pulse
ask.
form.
I can't promise that they'd be able to squeeze it in that
Yeah.
visit, but you can absolutely ask.
Okay, sometimes people just have to make an appointment for it.
Yes, yes. Insurance should pay for advanced care planning. And I can do advanced care planning with you as well. You don't have to have a terminal illness to do advanced care planning. Any other questions?
I have, and I'm not remembering the name exactly, but like, I don't know if anyone remembers 15, 20 years ago, they were calling something about death. It wasn't Dr. Death, but people were talking, does anyone remember that?
You mean,
Kavorkian,
You what?
Dr. Kavorkian.
Was it during that era? Yeah, I'm not sure, but they were talking, I remember hosting a meeting, and people were concerned about the different options and how painful they are. Like, I remember someone saying, I don't want to have water, I want to continue with water because withholding water is very painful. And I guess, is that still hold true, or I'm assuming they would give you something if you.
If you're on
Or
hospice, you mean?
discomfort.
So on
Not
hospice,
necessarily.
on hospice, you can eat and drink whatever you choose. If you are if you're at home and you are choosing to withhold food and drink, then that is a choice that you can make. But it's not something that a healthcare provider would withhold from you.
No, I'm talking about someone who has decided, because it says in here somewhere, something about, let's say, you know. with-
Oh, if you cannot eat or drink to sustain life.
Right.
Yes, so typically,
What does that feel like when you withhold something?
it depends. So if you have a terminal illness, your body will naturally dehydrate itself and you feel less hungry, less thirsty. That's the body is very smart. It knows how to die. When you're dying from a terminal illness or old age, it will dehydrate itself and that need for food and drink decreases until that feeling is gone. So if you have a terminal illness, you're not going to really notice that as much. You might have dry lips, you might have a dry mouth, and we can help, moisturize. But when you're that sick, your body doesn't feel hunger and thirst typically. Now, if you are a normal, healthy individual that has a stroke and all of a sudden you can't swallow, and safely, then that's a different story. You probably will feel hunger and thirst. But doing artificial hydration and nutrition is not necessarily going to fix the problem of aspiration, which is the risk of eating and drinking when you can't swallow properly. So that's a whole nother discussion. I can't answer that here. I'm happy to talk more about that with you, but it really depends on why you can't eat or drink and what stage of life you're in.
It's not whether or not you can, it's a choice that people are making. I think it was Dr. Death was the
Yeah,
saying.
so voluntary stop eating and drinking?
Yes, and what does that look like? I mean, is that painful? I think that's what people were talking about back then, is there pain associated when you choose not to hydrate or eat?
Yep, so if you are totally healthy and have no medical problems and don't have a decrease in thirst or hunger, you are going to have some discomfort with that. Normally in the first few days you will become confused and delirious after not eating and drinking, and then it becomes easier, but yes, it is a little uncomfortable at first. But that's something that you would want to have a good conversation with a provider about, and make sure that you have the tools in place to be comfortable and not do it necessarily on your own. Okay. Any other questions?
One of the problems I've had with filling out this form is COVID.
Okay.
Because I was pretty clear before COVID that I don't want interventions.
Mm-hmm.
But with COVID, there's a chance that with intervention, you can have pretty much the same quality of life afterward.
Yep. So you're speaking about intubation.
Intubation or I guess feeding tube isn't a factor for COVID, but so I'm glad to see there is an in-between place.
Yes.
But who decides what a short time is?
Yes.
I'm glad you brought that up. I have seen some folks that put in a time limit on there. For example, I had a patient not too long ago that put 3 days. I only want to be intubated for 3 days and then take me off. It left the family very conflicted, because what if you do have COVID and it takes you 7 days to recover from COVID? Then your family's pulling that machine a little premature, right, potentially. So I don't recommend that you put a time on that personally, because I have seen what that does to families. What I would say is that a short time, the way that the medical community is likely to interpret that is whatever the diagnosis is, what is the expected recovery time from that? So if it's COVID and you finish the treatment, the antivirals and the steroids and all the things, and you're still not able to come off that machine, then maybe that's the time, as opposed to if you have a traumatic car accident and it takes months for you to recover, right? Like that's a very different story. So I don't recommend putting time limits. If you feel strongly about that, then that's your choice, but it does make it difficult for your healthcare agent, especially if it's in days, like 3 days. I don't know where that number came from, but that meant a lot to them, and then the family was very conflicted. So the healthcare professional is going to take in consideration what the diagnosis is, what the expected recovery time is for that, and if you're improving, right? Like if you're not getting any better or things are going really south, then that's a sign that things probably aren't going to come out good on the other end. Yeah.
And so, I just have a really hard time with that particular one.
Yep.
Because if it is like a car accident and I'm really badly injured, I probably don't want to be. I don't want to be.
I tend to agree with you,
brought
depending,
back,
right?
I've
Yeah.
had enough pain already. I don't need more.
Yeah.
So, I'm conflicted about that one.
The one thing that we talked about earlier is that if you are in a car accident, the likelihood that they aren't going to start the process of resuscitating you before they figure out that you have a do not resuscitate is pretty high, right? Like the ambulance rolls up to a car accident, they're gonna start doing the things to save you unless you have a bracelet and they happen to notice it. But, so resuscitation for a traumatic injury is pretty likely to happen out in the wild, right? If you're, if you're in a hospital setting, that's different, right? But if you're in, you know, or you're on vacation and you don't have your forms with you, the likelihood, just like you had mentioned, that something's going, the resuscitative measures, because the standard default is do everything. Because we don't know always. And you can't take back what you didn't do. So we have to do everything. We can pull the plug later, but we can't.
So another quick question is, you said you could meet with us to help us with these forms.
Yeah.
Personally at home? Or-
Yeah. Yep, we'll set up a time and I'll come meet with you and we'll do the forms, we'll talk about it. We'll go over your medical history too, because that might play a role in your decision making. And then we will make sure that the forms are completed and we will get them to the appropriate places.
Okay, and is there a charge for that, or is that?
Insurance covers it typically.
Really?
Yep, Medicare, Medicaid, and private insurance. So most insurance covers advanced care planning.
Okay.
And can I add something
Yeah.
quickly? Kelly's the expert, but to your point, I think that's why having these conversations with your healthcare agent is really important. You can't define everything
Right.
in this.
Exactly.
But if you're in that situation, you know, the healthcare community will reach out to your healthcare agent, and hopefully that person has a sense of your general wishes. So I think we're filling this out, but we're also communicating those wishes to the people who we've named. And there's actually a packet in there that has some tips for starting those conversations, which, you know, aren't always easy. So.
Yeah. And that's something I can help with too. You know, if you want your agent involved in that meeting, we absolutely can. If it's somebody, we can do family meetings after the fact that the forms are filled out and have a good conversation with them. But just first and foremost, make sure that they know that you have chosen them as to be your agent.
Did you say this was, that your service was covered by
Most insurances, yes.
insurance? Is it Medicare as well?
Medicare, Medicaid, and private insurance typically. Yep. My services are billed exactly like a doctor's visit. So if you have a copay for annual physical, then you might have the same copay for my visits. Most of the time, they're covered completely, from my understanding, what I'm told. Any other questions?
What are you gonna do with this information on this?
We'll follow up with you, and if you want to have a conversation
Yep.
with Kelly, we can facilitate that.
Or otherwise, can we email you and set up
Yeah, absolutely.
at some point in
Yep.
the future?
Absolutely.
Where are you based?
I work out of Central Vermont Home Health and Hospice in Barry.
Here?
Yes.
In-
Yes. I serve all of Washington County and parts of Orange County.
If you update your form and everything's the same, can you just change the date and like initial it, or you have to do it?
Not technically, no, because it's witnessed by those two individuals. So legally it should be, it's not notarized, but it should be treated as such, that it's a notarized legal document.
Great, and thanks for having them here today. Where's the
Yeah.
best place to get them?
You can get them online, so if you just go to the Vermont Ethics Network, they have it there. There's a short form and a long form. They're pretty much the same, except for the long form goes into much more detail about your personal wishes surrounding burial and all the things. So that might be a good form for you to fill out too, for green burial. Yeah.
Is that office, like, are there people there, or is it just an online?
Which
Where they?
The Ethics Network or
Yeah,
our
the ethics-
office?
The ethics.
They have someone there. Yeah,
Yeah.
I mean, they're right on,
Yeah, I know, I see.
yeah.
Yeah.
I think I'll.
There are people there, but I would email or call
Yeah,
to
you-
see. Yeah, she's all over the place, yeah.
They have a copy of my other one.
They probably sent it to the registry. So any of the other, they're not the registry. So they would take the information and then register it. But it's not, you can do the form on your own, and register it.
Well, it says somewhere on the web that you can update
Yeah,
without, going through all the signatures again, but, I'm not sure how that would work.
Any other questions? Well, I appreciate everyone coming out, and hopefully this was helpful.
Yeah.
Yeah, of course.
Thank you
Thanks.
for doing this.
Of course, happy to.
Informative.